Hi, everyone. Welcome to one of the first events of this year's Public Health Genetics Week. To give everyone a little bit of context, Public Health Genetics Week is hosted by the National Coordinating Center for the Regional Genetics Networks, which is supported by the Health Resources and Services Administration. The goal of Public Health Genetics Week is to raise awareness about public health genetics. And so we're very excited today to have three speakers to talk about the role of education in public health genetics. And with that, I will pass it off to Andrea Durst.
Hello, everyone. I first wanted to start by also welcoming everyone in attendance to the first day of Public Health Genetics Week 2022. And as a brief introduction, as Megan said, my name is Dr. Andrea Durst, and I'll be one of the presenters as well as the moderator for this section today. For this webinar, we will be providing an overview of public health genetics with a focus on education. Myself and the two other speakers today serve in a number of positions, but we are all brought together by the American Public Health Association's Genomics Forum, which provides a place for professionals who are interested in public health genetics to come together and share ideas, work on joint projects, and network together. So if you're interested in learning more about the APHA Genomics Forum, I've included a link at the end of our presentation today. You're also welcome to reach out to me with any questions. And so with that, I'll move on to an introduction of our speakers. Today, I'm being joined by two additional speakers, and we'll be covering each a different section of the webinar. So I'll be starting off our webinar today with an introduction to public health genetics. And as I said, my name is Dr. Andrea Durst, and I'm the director of the MPH Public Health Genetics Program, as well as the associate director of the Genetic Counseling Program in the School of Public Health at the University of Pittsburgh. I'm joined today by Dr. Karen Niemczyk, who will be speaking about genetic literacy. Dr. Niemczyk is an assistant professor in the Master of Public Health program at Grand Valley State University, where she also serves as the practicum coordinator for the MPH program. And our third speaker today is Gail Marcus. Gail is a state genetic counselor in the Division of Child and Family Wellbeing in the Whole Child Health section of the North Carolina Department of Health and Human Services. During her presentation, she'll be sharing some of her work in her role as a state genetic counselor. So welcome to all of the presenters today. As we move into the presentations, I wanted to remind everyone participating to please enter your questions for myself and the other speakers into the chat, and we'll hold a question and answer session at the end of all three presentations, so at the end of the webinar. All right, and so with that, we wanted to start the presentations today by providing you with a brief introduction to public health genetics. I know Megan gave a brief introduction, but we're going to dive into a little bit more detail here, focusing on some of the important aspects of education in this new and emerging field. And so just to get us all on the same page, I wanted to start out by describing public health genetics in the context of precision public health and clinical genetic services. So precision public health is defined as providing the right intervention to the right population at the right time. You may have previously heard of precision medicine, which focuses more on individual care. And while similar, the main difference here between precision medicine and precision public health is that focus on populations. And so precision public health relies on a lot of different things. So the use of technology, big data, and enhanced health surveillance to increase health and health equity across populations. Public health genetics is one important component of precision public health, and it can be used as a tool to identify at-risk populations for certain diseases or conditions. It can be used as a way to collect data and look at data sources for surveillance of genetic conditions, and also to facilitate the implementation of programs to connect those at an increased risk for disease with the appropriate genetic services on a clinical basis or research basis. And then public health genetics is defined as the application of genetic and genomic information to improve public health and prevent disease. It really does provide a scientific, ethical, cultural, legal, and policy context to ongoing advances in genetics and genomics in order to realize the goal of improving public health. And it also helps to advance health equity by ensuring everyone has access to information and care that can help them to be as healthy as possible. Public health genetics also encompasses many activities that influence clinical services, including policy development, education of patients, of the public, of providers, of public health professionals, and also the engagement of communities. And so, as you can imagine, there's a great need for education that's interwoven into public health genetics initiatives, including the education of the public and healthcare providers, public health professionals, researchers, policymakers, to name just a few, as well as the training of up and coming public health genetics professionals. And this is why education is such an important aspect of what we do as public health professionals and why we wanted to focus on education today during this webinar. All right, so the field of public health genetics and genomics is also grounded in the 3 core public health functions and the 10 essential public health services. And so as you can see on this slide, the 3 core functions include assessment, which refers to the collection, the investigation, and the sharing of information about health conditions, risks, as well as resources that are available to the community. And then moving on to policy development, which this is really the development of health policies at all levels. So including at the community level, maybe at the institutional level, like hospitals and national organizations. And then also, as we tend to typically think of policy at the local, state, and federal level as far as laws, to name just a few examples of where policy development can be taking place. And then thirdly, we have the core function of assurance, which focuses on ensuring that public health services are available to the people who need them. And so assurance is often focusing on access and maintaining a robust, diverse, and informed public health workforce. And so again, education is an important aspect of each of the 3 core public health functions and many of the 10 essential public health services. Education can help in understanding what to assess and why it's important to assess that. It can help to mobilize communities around an important issue and can help to inform policy development. And is definitely needed to maintain an up-to-date and educated workforce on these issues. And then, while these essential services are generalized to embody all areas of public health, there have been a number of efforts to also take these and make them more specific to public health genetics, as well as, other areas of public health as well. And so again, this is an outline of some public health genetics and genomics initiatives as they relate to the 10 essential public health services. And this is a graphic that has been created actually specifically for Public Health Genetics Week. This is also available on the Public Health Genetics Week website, which you'll see referenced on the bottom of many of our slides today. It's also a really nice resource to just highlight some of the initiatives that are centering around education and the public health initiatives that are really prominent and being explored in the field right now. And I've marked a couple of them with stars that show where the public health initiatives that are really focusing on education, just some examples of those. All right, so this slide contains an image of another one of the fact sheets that have been developed for Public Health Genetics Week. And this outlines many of the individuals who are involved in carrying out public health genetics initiatives. So as you can see, there are a lot of individuals and organizations that are involved in public health genetics, including hospitals, universities, advocacy organizations, genetic testing companies, public health agencies, researchers. There really are just a number of different individuals and organizations that are involved in bringing these initiatives to the public. And given that public health genetics is a relatively new field, education in genetics, public health, or both is often needed to ensure that there's an awareness and understanding of the issues that are the focus of some of these public health genetics initiatives. So for example, if we take newborn screening, which is one of the most well-known and successful public health genetics programs, newborn screening involves education at a number of different levels, right? So we need to educate families about the screening that is being done, pediatricians about the conditions that are being screened for and how to follow up on a positive screen, as well as public health professionals who might be overseeing those programs on a state level, and healthcare centers who are kind of overseeing the process for collecting and sending samples in for screening. And newborn screening, again, a very important public health genetics program that helps identify specific genetic conditions in newborns so that we might be able to intervene and to either prevent or lessen some of the symptoms of those conditions as those newborns get older. All right, so why is it important to focus on public health genetics and increase awareness of genetics and access to genetic services, both during this week, Public Health Genetics Week, and beyond? It's because we now know and are continuing to learn that genetics is a contributing factor to many, if not all, of the top causes of death in the United States. So for example, there are genetic factors that can increase a person's risk for heart disease, cancer, stroke, Alzheimer's disease, and other conditions and diseases as well. And family history is also an important consideration when we're thinking about risk assessment for many of these conditions and causes of death. And then genetics can be important for infectious diseases as well. So in determining, for example, the strains of flu that are being seen in a given season, or as we've recently seen in the development of vaccines. And so as such, there really is a need for a consideration of genetic risk factors in family history to be incorporated into many existing public health initiatives. So for example, important in initiatives maybe to diagnose or to decrease the number of diagnoses and deaths from heart disease or cancer. Genetics is also becoming more of a part of routine medical care, and this requires education of providers and hospital systems, as well as a focus on ensuring that genetic services are able to be accessed by all those who need it, and that those services and tests, where appropriate, are able to provide the best possible care to all individuals who are seeking them. All right, and with that, I will conclude my presentation. Thank you for your attention today. I'll be happy to answer any questions during the question and answer portion of the webinar, and also to answer any questions by email, and I've included my email up on this slide for you as well. I'm also happy to answer any questions about the MPH and Public Health Genetics program at the University of Pittsburgh. And with that, I will now turn it over to my colleague, Karen Niemczyk, who will be discussing genetic literacy.
All right, well, hello everyone and welcome, and thank you for being here actually. So this is, there's so much that could be said about this particular topic, but we're going to kind of brush the surface, if you will, based on the time frame that we have, but hopefully it's enough to understand the importance and the role of public health genomic literacy in education. Next slide. So I thought we need to start out with a particular definition, so we're all on the same page here. So the textbook definition says it's the degree to where people have the capacity to obtain, process, and understand basic health, in this case, genomic information that they need to have a say in their own health decisions and their individual health decisions. And you might say, well, how can we tell if someone has this or not? So it's measured through a few different ways. First of all, what do they understand the concepts? And also sometimes it's within the context of their own culture, because cultural knowledge is different for different ethnicities and people groups. We also like to measure it through oral literacy, meaning they can listen to and hear health and genomic information, and then are able to also speak it back or understand someone speaking that to them. There's print, being able to read and write these types of terms and these concepts. And then there's numeracy, everyone's favorite, quantitative skills. And these are very basic, and we're going to get into them a little bit more, but you'll be able to see just how it sounds like it's very complicated, but it's not. Next slide, please. So let's see where we are in the United States. So in the United States, it has been found or estimated that the average adult reads at about an 8th grade level, and 20% of the US population reads at the 5th grade level and below. And this equates to about 62 million people, or the populations of those 3 states that are listed there. It typically tends to affect people over 60 years of age. Obviously, these people have not had a great deal of experience with genomic and genetics in general, because we have really rapidly increased our use of genetics as a field in both medicine and public health. Obviously, people who are immigrants will have difficulty not only with the language barrier, but also with those terms. And also other ethnicities, races and ethnicities other than whites tend to have a different or have more difficulty as well. It is estimated that 50% of the Hispanics, 40% of Blacks, and 33% of Asians tend to have some type of health literacy issue. And then finally, those people who we would find would have lower income, be in a lower socioeconomic status, will also have difficulty with health and genomic literacy. Next slide, please. Another study found that they estimated only about 12% have proficient health literacy. What is proficient health literacy? That means that they can complete certain tasks like calculating their own share of health insurance costs using some type of a table that was made available to them. And then they found that 36% of the population were at basic or below basic health or genomic literacy. And basic means, just for your information, they need to have the skills to perform simple and everyday literacy activities. And then below basic is going to be less than that, just the most simple and concrete literacy skills. Next slide. So the contributors then overall, just kind of summing this up, that we find related to health and genomic literacy. Obviously, poverty level, we mentioned that. Insurance status, we didn't really talk about that. Those individuals who tend to be on some type of public assistance, such as Medicare or Medicaid, would not be as proficient as someone who had privately held insurance. Education level, race, ethnicity, the non-white races. Age, those older individuals greater than 60 years of age. And they also found that people who have disabilities would also have difficulty. And this is interesting because these are people that their disability may be caused or have some type of a genetic component, and they would need to be able to understand that in living with that disability. Next slide. Who needs health literacy or genomic literacy? Well, this is the list of people. Obviously, being in higher education, I focus greatly to a large extent on students, but I'm also involved in other organizations where it has been, and it's well known in the literature, that physicians particularly are not as proficient in genomics as you would think. They may be part of that. We're really starting to take a look at that. And it seems to be that the medical education in some programs tends to be lacking in that. Nurses, other health professionals, patients, obviously patients need to understand what's being spoken to them, diverse populations and underserved populations as those that are defined as such by the government. Next slide. All of these things have been found to be connected. Health or genomic literacy will determine the use of health and genetic services. If someone does not understand genetics, it's much more likely they will not seek out or attend appointments for genetic services after being referred there. And that then is connected to their health status, because if they're missing out on genetic services, then they may be missing out on ways that their health can be improved or other issues that they have could be mitigated through the understanding of what we know of genetics and disease. Next slide, please. So a question was asked, is this the perfect storm in this time frame that we're in genetics and understanding? So these three things: we currently have high rates of limited health literacy. We have increasing complexity of health information, which really was highlighted throughout the pandemic, not only using an mRNA shot that was developed against COVID, but also even things that we might understand that are also complex just about the human body. For example, the immune system, which is a very complex body system, and having a lack of understanding in that as well plays a role. And then finally, we know that we have increasing access of diverse populations to health services, and they need to be able to understand. And so all of these factors combined together may lead us to the point of we have serious issues that need to be addressed in order to help individuals, doctors, health professionals understand exactly all of the components, at least the basic components of genetics. Next slide, please. So what are some of the problems that have been evaluated? It has been shown that there are effective communication gaps that contribute to health disparities that you maybe have heard of before. This is a big issue in our healthcare system overall. There was also a study that was done, and I'm not picking on genetic counselors at all. This was just a study, and this could be applied to probably many different healthcare professionals. This just happened to be a study that was completed. And they were looking at the information that genetic counselors were giving to patients, and the difference between what the information that was being provided by the genetic counselors, but what the patients felt were important. And so these were some of the things. This study was completed where they had patients come in and have a visit or consultation with a genetic counselor. They then sat in on it, and the researchers, and then they also interviewed the genetic counselors and the patients after the encounter. So they found that the patients found that there was too much information. They felt that 40 to 80% took up the conversation of just patient information on genetics in general and on those topics. The terminology seemed to be difficult for the patients. Some of the presentations were difficult for them to understand. And the patient engagement opportunities then, because of all that, the time that was spent on the information seemed to be lacking to the patient. They also felt that there were vague discussions. Next slide, please. So this was from that study, and they put this chart together, and they showed, and this was a typo in the study, not mine, information provided from the counselors is on the left-hand column, and what the patients wanted to know. And I don't want to read through all this, but what's interesting is if you look at the information that's being provided them as far as the genetic topics, the patient really brought it down to a very simplistic level. They want to know things like, and they understand, I believe, from this study at least, and probably most people do understand heredity and the ability of information to be passed on from parents or grandparents or down to their children. So what the information that was being given, you can see that on the right, what the patients were interested in were very simplistic ideas like, is my cancer hereditary? Can I pass it on? Am I going to get cancer? Is my cancer going to come back? The basic types of questions that you would expect patients would be interested in knowing. The gray box at the bottom that you see showed an overlap, and it was one of the only ones that they were able to find. And it was an overlap between the information that the genetic counselors were giving to the patient and what the patient wanted to know. So they found in their themes and going through all this information that there was a little bit of overlap, meaning the patient was getting some of the information they were interested in from this last bit as far as what patient and family members can do. And that tended to be really centered and focused on, as far as the patients were concerned, dealing with themselves and their family members and what could be done based on what the genetic counselor was speaking to them about. Next slide, please. So that's one side of some of the problems that we can see currently in this area. So for public health education, I'm going to focus on that because I'm also part of a Master's of Public Health program like Andrea is. Back in 2003, it was already being talked about that public health professionals need to start thinking genomically. A few studies, these are just some very short highlights of a few studies that were done in 2007 to 11. They actually found that the number of genomics courses were decreasing in public health education programs. In 2013, they looked at a random selection of CEF accredited schools, and they found that only 7 of those 20 that were randomly chosen had any type of genomic offering for students. And then finally, in 2018, out of 171 CEF accredited schools, we looked at, this was a study I was a part of, and actually what we looked at was to see what types of genomic offerings were there, if any. And you can see by the chart there, 59% did not have any offerings whatsoever. You can see that 18.1 was related to genetic epidemiology, which was great if a student is going into that. Then the other was genetic biostats and bioinformatics. And then finally, the lowest number, which was, sorry, I almost can't see that, looks like 8.2%, the public health genomics and genetics courses were being offered for students. Next slide, please. In a follow-up study that I was also a part of, Andrea was a part of as well, we did a 14-question survey. We had a 22% response rate, and we really wanted to find out from that initial study what was going on and what were some of the reasons behind the low numbers of courses being offered. So 38% offered introductory courses, but 71% of those 38% were not required. 70% did include genomics topics and other courses, but again, 38% of those were not required as well. And then finally, and we had a lot of questions, but I found that these questions were some of the most interesting. On a scale of 1 to 10, we asked the program directors, chairs of departments and things like that, how well they feel that their curriculum met the needs of 8 Centers for Disease Control competencies for public health workers in the field of genetics. And overall, the average was 4.4. So not even half of them felt they were meeting well. Their curriculum was meeting well those 8 competencies. And the largest barrier, there were several barriers to why they felt this might be the case. And the biggest barrier that they felt was time and space within their curriculum. So an interesting problem for sure for the public health programs that are out there. Next slide. Answers. This has been coined the Health Literacy Universal Precautions approach. And basically what it means, it's very simple. Use plain language. They put all the responsibility on the healthcare professional, and that they needed to have these characteristics. They need to be committed, they need to be sensitive, flexible, and practice, because this was definitely a skill and not something anyone just has innate within them. And finally, they needed to confirm patient understanding when they were with the patient and sharing this information with them. So some of the speak back type of a thing, can you repeat what I just said to you to make sure that they understood? So very quickly, just some of the problems, some of the overall statistics, and some of the things that, some of the research that's out there and what we're finding about it. I want to say thank you for this, for listening and for your interest in this topic.
Thank you, Karen. I'm going to turn it over now to Gail for her presentation.
Hi there. My name is Gail Marcus, and like the slide says, I am a genetic counselor and I work in North Carolina. I cover the state currently. When I started in my position a little over 20 years ago, I just covered 1/6 of the state, but there has not been the support and the funding for the program, unfortunately. So as people would leave to get jobs that paid closer to what they should be earning, they did not increase the compensation. It was very difficult to get people into the program. And I find that that's really sad. North Carolina has had quite a gangbuster sort of step up to the plate, one of the earlier states, I think, in doing so. But I still love doing the public health aspect of genetics. So now I cover the state. Let's go to the next slide, please. Ellen. So there's different ways to look at public health genomics, and the narrow focus, which is more of what I actually deal with, is more clinical Mendelian, some multifactorial, but access to care, affordability and genetic testing coverage, and education of providers and the public. But when you think of public health genomics, again, like what has been mentioned by Karen and Andrea, is there's a much broader aspect to it. And I think of that with COVID quite a bit. So why are some people getting COVID more than others, even if they don't have comorbidities or have a reduced immune situation? So there are some unexplained situations, and I think that probably is going to go back to genetics. And so there are studies that are being done in that. GWAS and the susceptibility regarding vaccines and illness, development of new vaccine technology, and then the environmental exposures that increase health burden and epidemiology. So pockets of increased disease and environmental link. I know where I live right now in North Carolina, in the specific region, we've had a lot of our water supply that has been polluted by industry that actually is 2 hours away. So we don't know what the long-term effects could possibly be in the population for that, but there will probably be a subset of the population that'll be affected with certain kinds of conditions. So I think that fits very well into public health and different concerns that the population would have. Next slide, please. So in North Carolina, we actually developed a genetic and genomic health plan. And the plan is a narrow focus, seeing the bigger picture. So North Carolina convened a stakeholder group in 2018. We met 5 times over 18 months to update the genomic state health plan. This initial health plan was actually developed in 2004, and there had been funding to develop the plan at that time. Not to take it past the actual development of the plan, but at least for the plan itself. And that 2004 plan, when I read it, I was really impressed. It was very visionary. It was made up of over 90 stakeholders, from medical genetic professionals to industry leaders and government. And there were action points listed in the plan. However, no advisory committee was actually established from the 2004 plan. So the actions that were stated in the plan weren't actually tracked or implemented. So it was a very bold and collaborative effort, but it was difficult to implement due to lack of designated funding at that point, even though there was funding for developing the plan. Just to see it through, there wasn't. So kind of like all that momentum just stopped. Next slide. Next slide, please. So we went ahead and decided to update the plan. And there was a leadership team initially that was formed, and it included a clinical geneticist who happens to be the current president of the North Carolina Medical Genetics Association, a branch family partner, and those two were each a co-chair. Myself, the state public health genetic counselor, the branch pediatric medical consultant, and the genetics and newborn screening unit manager. So us 5 are that core group. Next slide, please. So putting it together then, I reached out to actually quite a few of the people that were on the 2004 plan, and then reached out to other individuals that I was aware of that are current in the state as well. So there were several state and national partners who were asked to participate in key informant interviews and provide feedback to help with the development of goals, objectives, and actions for the plan. This included, but was not limited to, representatives from the American Public Health Association, Office of Public Health Genomics, Center for Surveillance, Epidemiology, and Laboratory Services at Centers for Disease Control and Prevention. There were 5 in-person meetings this is before COVID, that we held between September 2018 and May of 2019. Initially, there were 100 stakeholders invited to participate, either in person or through electronic communication. We even had one individual who came in via phone. So we never had 100 folks actually attend, but that's how many were sent the initial emails if they were interested in partaking. Next slide, please. So the current genomic health plan was fully approved in the spring of 2020. Two very big changes from the 2004 plan was that we did have organization for a genetic and genomic advisory committee. There is no funding for any of this. So there was no funding in this case to update the plan. So there was funding in 2004 to develop that plan. We've had no funding at all in this process, but we still had people that were interested. So we were able to put this advisory committee together. The makeup of the group consists of genetic professionals and parents, totaling 18 members. 25% are parents. So that was the number we came up with as far as how many parents and their views that we wanted to be on this. And some of those parents also are healthcare professionals themselves. So they kind of overlap, which is nice. There's much more concise document targeting in the more recent plan, in this 2020 plan. We had three primary areas of focus: genetic access and testing, education and communication, and epidemiology and surveillance. Next slide, please. Stakeholders of updating the plan focused on putting together actionable steps with the hope that the plan would breathe and have a life of its own and produce results. So that was the big change from the 2004 plan, as we didn't want it just to be a white paper. We wanted it to have some value that would eventually translate into day-to-day results. So we aim to recruit members from broad areas. So the stakeholders are medical practice, education, health systems, advocacy, research, and state level agencies. And the three groups, initially what we did is we got the people that were interested, that were going to become members. We tried to have them be in groups based on their main interest. So we have a breakdown of 8 members in the communication education group, 7 in the genetic access and testing, and 3 members in the epidemiology and surveillance. All of this is sort of a moving, evolving group, though. So breaking it down into these 3 groups is probably going to change. Next slide, please. So the overall goals of the strategic plan for each of these 3 groups: genetic access and testing, the hope is to ensure quality, comprehensive and timely access to genetic and genomic services, including evaluation, testing, follow-up, and social support. And that does sort of tie into what Karen and Andrea were focusing on. I think that follow-up and social support is so important to families. And having that, just having the access and knowing where to go, having a provider who actually knows when and how to refer, that's a big one. Epidemiology and surveillance, enhance the capacity for public health to collect, analyze, link, and store genetic and genomic data to monitor health outcomes of individuals and populations in North Carolina. What we have found out with this is that some of the groups, like the Birth Defects Registry, for instance, they collect actually very, very, very little genetic data on populations. But adding questions to those registries is not easy. The ropes and the channels you have to go through. And to develop new formats to collect data, if they have to be approved by the legislature or something like that makes it very, very difficult to then develop an epidemiology and surveillance situation that might be better serving public health overall. So for instance, the cancer registry, it doesn't collect, it'll collect numbers. And I think that possibly part of its focus is to look for clusters, environmental clusters, which is huge and is important, but it doesn't, for people who've had cancer, it doesn't ask, well, have you had any testing done? Have you had any genetic testing and what are those results? So there's a lot of things that it doesn't monitor that would be nice to be seen on those registries. Education and communication. Increased genetic and genomic awareness, knowledge, skills, abilities among healthcare providers, patients, and the general public. Healthcare providers, that's huge. I think if healthcare providers were appropriately educated, that patients and the general public would have more awareness as well. Next slide. So the first 18 months, this has been a real sort of a roller coaster, but it's also it's been a real learning situation for us. So the first 18 months for the advisory committee, we met virtually because by then COVID had hit, we were shut down. So for the first year and a half, we met for a 2-hour call quarterly. In between the quarterly calls, there would be a subcommittee call to work on certain action steps. Each subcommittee has the leeway to modify or change action steps as needed. We asked individuals that first were applying to be part of the group to give us a 2-year commitment, with new members being transitioned in and out gradually rather than all at once, so that we can help transition people and immerse them rather than have to sort of learn everything from the beginning again and having a whole big group of people. As of 2022, we decided to meet every other month for a 1-hour call. We've had a lot of issues with attendance. It's been a very difficult challenge for us. Next slide, please. So there is lack of funding. That's one of our big challenges. I think with funding, the people who are doing the funding give you what they, requirements that they want at the end. So it holds people accountable. So I don't think it's just money per se. I think it's the accountability to the group that you've chosen to be part of. So the initial members are very eager to be part of the group, but attendance has been between 25 to 50%, with really just 25% being the norm. Finding a time and day for more members to attend, we've sent out Google surveys to see what works best, and it's just been an up and down fluctuation. So there were thoughts of increasing the numbers, and people higher up than me don't want to do that. I would like to see that, not by a lot, but maybe up to 25 to 30 members, I think would really be helpful. Engaging more industry leaders and policymakers. And if we could meet just 1 or 2 times a year in person, even though people have to travel from different areas of the state, I think that meeting face-to-face would help with that engagement to keep that momentum up. So those are some of the challenges that we've had, but I'm not aware of any other state that has an up-to-date genomic plan and that actually has developed a genomic advisory committee to implement. So hopefully what we learned from all this might be help to other states at some point if they want to try to pursue this. Next slide, please. So some interesting learning points so far is breakout groups to work on projects works better than working from subcommittees. So initially we had subcommittees. We'd have a subcommittee call in between our whole group calls. And what we've decided to do is, rather than
DJ Gloria Cell,
break down those subcommittees, is to have people still have their focus of interest, but to stay working from the large group. And because that way, if you have an interest in education and communication, but there's one project that's being done by the genetic access and testing group, you can say, well, I want to work on that project. Even though I'm in this group, or this was my main focus, I want to work on that project. That's very interesting to me. So it allows for more flexibility of the members, and hopefully, again, for better engagement. Still working on that time and day. We have a survey out now trying to collect some of that before we go into our next major call. Testing out how to recruit new members as older members transition out. And should we have an every other month 1 hour call versus quarterly 2 hour calls, and finding that sweet spot. So those are still things that we're working out, and hopefully we'll figure it out. It's been a really interesting learning project for me, and I think for the folks that have been committed and have been showing up. Next slide, please. So a little bit more of what I do that is not necessarily the Genetic and Genomic Advisory Committee. I do act as a consultant to providers, and I create presentations for webinars. I do direct patient care also when needed, involvement in national and global genomic endeavors as well. And I head up the Genomic and Genetic Advisory Committee. As far as, I want to go back to education for a moment, is that trying to get providers to make referrals. I cover the state, and I get very few providers on a routine basis making referrals. I'm hoping that they are making them to the medical centers, but I know that the difficulty with access to genomic providers, not just in North Carolina, but nationally. There aren't a lot of medical geneticists. And when you need to actually have that medical evaluation, it's very difficult. And I don't think that providers are making those referrals as needed. And it's due to lack of education. One of the things that I have pushed is for the healthcare, for the core competencies in genetics for all healthcare professionals. That is overseen by Jackson Laboratories at this point. And just as an example, and I won't name names of universities, but two specific universities in North Carolina, they're part of the state education system, so they're not private. One of them, in their nursing program, has required a clinical genetics class, so it's part of their core curriculum. They have had that mandatory since 2002. Another university I've dealt with, I have beat my head against the wall for over 15 years, and they just are not interested. They don't have time. They have space, but they don't have time. And I see it as they don't have time to educate their nurses, period, because I see genetics as overseeing all of health and not just one area. If a nurse wants to become a pediatric nurse, or she wants to become a cancer nurse, or it oversees everything, how can they not have it? So there is a really broad discrepancy in the education that is offered in training programs. So that's just a frustration, but that education is so key. Next slide. I think that I'm pretty sure that was it. So if you have any questions or suggestions, just feel free to reach out to me. Thank you.
All right. Thank you so much, Gail. All right. Well, we have now entered into the question and answer portion of the webinar. So if you have any questions for myself or the other speakers, please feel free to put that into the chat.
We welcome comments as well.
And comments, yes. And this is the website here for the APHA Genomics Forum, if that is a group that you are interested in checking out. All right, we're not seeing any questions in the chat so far, so we'll give people maybe another minute to collect their thoughts and put them into the chat. And if we don't have any questions, you can please feel free to get in contact with any of us directly, and we'd be happy to answer questions after the webinar as well.
I know I'd be interested to hear any thoughts that you have even on any of the topics that we talked about as well. It doesn't have to be a question. Be interesting just to hear different perspectives.
All right, well, it looks like nothing is coming across the chat today. And so again, if you would like to talk, oh, I have a wait, hold on. Okay, so the question that came through the chat is, I'm wondering if a career as a public health genetic counselor is different from a traditional genetic counselor. And so I can tackle that one first, and then Gail, love to hear from you as well. And so as far as a genetic counselor who's taking on a public health role, first of all, what I always like to stress is that I feel like most genetic counselors do at least part of their practice in something that is related to public health. And we just don't realize it, right? So as genetic counselors, often we are participating in the education of providers, of the public, of our patients. And so we have a really big role to play as genetic counselors in the education piece that's so important in public health genetics. You know, I think that a big difference, again, between really thinking about public health versus individual patient care is that focus more on populations than on the individual patient in front of you. Now, certainly, right, those kind of job outlooks on what it is that you're doing in your job can overlap between public health positions and clinical positions. But I think that that's one of the major differences that I see. Gail, I wanted to turn it over to you to maybe add some more.
Yeah, I really totally agree with you. I think that the education piece, I think all genetic counselors, even the ones that do direct patient care, you're educating the patient. So we all do education on some level, but as a public health overall in the larger groups, the education piece of, again, existing providers as well as in training programs is huge for those, so they can just provide appropriate genomic access and care, but also to help educate the public and their patients. So I like, for me, public health, just on a personal note, I like it because I haven't been pigeonholed into a certain type of genetic counseling. I'm not just a prenatal genetic counselor or a pediatric genetic counselor. I can do all of it. But I'm also given the opportunity to do more education than if I was in a traditional genetic counseling position. And because that's so near and dear to my heart and has been since day one in this field, I think that I have the opportunity to try to be an ambassador a little bit more for that than I would otherwise.
Yeah, great. Thank you, Gail. And I also wanted to stress, that I think there are a lot of opportunities to have a career in public health genetics that is not related to genetic counseling and doesn't require the training to become a genetic counselor. And so in our MPH public health genetics program at Pitt, students get training in both human genetics as well as in the, core public health disciplines, and they're able to apply those skills and that education that they learned in a number of different settings, from research to patient advocacy organizations, precision medicine initiatives. There's a lot of opportunity out there. And so if you're interested in genetics and public health, I think that, thinking about different ways that you might bring those two things together can be really helpful. And I think there's a huge need, as the three of us, I think, have outlined here, for professionals who are educated both in the public health side of things and in the genetics side of things. Karen, did you have anything to add to that?
Yeah, actually, I was going to say, as I was shown in my slide, it tends to focus around epidemiology. And so I am in epidemiology. And so the students that I have typically are part of our epidemiology program. We also have a health promotion side as well. But I've had some health promotion students, they tend to run from genetics. I'm not really sure why. Genetics is fun and interesting and important and all those things. But what I have found, and what I will tell you is, and you're right about the population versus the individual, but what I found in the students, the epidemiology and health promotion students who come to my class in public health genetics, they don't really understand what they would do in the field. And you asked specifically about a genetic counselor, but this could be any type of public health professional. And what would you do with genetics in the field? And such a growing field. I don't even know that if we named A, B, C, D, that we would be hitting it, because I don't know that we even know what's coming down the pike. There's so many changes so rapidly and so many things coming into play. We all understand about newborn screening and public health. Gail was talking about the pediatric side of things. Those things we're very well aware of. The cancer epidemiology, that's a very large field in epi. So, and there's obviously genetics as part of cancer. So I think the sky's the limit right now. And working not just for a typical healthcare organization, but even private industry, where they need health educators who understand populations and health at the population level, and then understand genetics at the population level. I gotta believe that there's a lot of, that's just a growing field. Mm-hmm. So, yeah.
I would agree, a lot of opportunity out there.
Mm-hmm.
Right. We have another question. And so this question asks, how can I use social media to more effectively engage in public health, in public education in genomics?
I'm not a big social media user, so I don't know if I'm the right one to answer. I can go by what I hear my students talk about. So I know there are lots of things. First of all, there are events like this where Twitter's being used, Instagram, LinkedIn, all these types of social media things that are out there. There are groups that are talking, and obviously the ones that you follow. So I'll use LinkedIn, for example, because I am on there. Oh my goodness. I know that, whatever. Anyways, that's going to mock myself, but that's okay. I won't. So the people that I tend to follow, or that I am interested in hearing what they have to say, are in this field. And that is definitely one way, is just by engaging and participating in those comments and conversations and threads that are out there in the topic. And you never know what comes from that, who you meet and where it leads. So yeah, that's what I would say.
Yeah, I would agree. There's a lot of great content being put out there by a variety of different individuals and organizations, and using your social media platform to, like and share that information, I think can be really helpful, because that's now reaching your network of people who may not be tuned into all of the same, public health genetics resources that many of us are tuned into. And so just increasing the reach of some of those posts and tweets can be really helpful. And then, if there's something that you're particularly interested in and you want to share that information, I think that that's great as well. Getting accurate information out there that can get people interested in the topic and thinking about things that they might not have thought about before, I think can also be really helpful.
Mm-hmm.
Gail, anything to add there?
No, I'm good.
Okay.
Good, thanks.
All right. Well, I know we are right at 4. I do see, I think there's one other quick question we can maybe do in the chat here. This question is asking whatever happened to NICHPEG, the National Coalition for Health Professional Education in Genetics. And so I believe that some of the operations of NICHPEG were taken over by the Jackson Lab. Is that correct? Yep. Okay. Yes.
Yeah.
So Megan is saying yes. And so, you know, those similar resources are still available out there if you look at the Jackson Laboratory website. All right. Well, that is the end of the questions, and we are right at time. So thank you all for joining us. And, you know, we look forward to continuing the conversation and maybe seeing some of you over in the APHA Genomics Forum. Have a great day and a great Public Health Genetics Week.